Thanks, Jess. My name's Amy Parker. I'm a Senior Research Policy and Practice Fellow and Strategic Projects Manager at the National Ageing Research Institute, otherwise known as NARI. Welcome to our online Seminars in Ageing program. I would like to begin by acknowledging the traditional owners of the land on which each of us are meeting today. For me, that is the Wurundjeri Woiwurrung people. I would also like to acknowledge the traditional owners of the lands and waters across Australia. I pay my respects to elders past and present and to all Aboriginal and Torres Strait Islander peoples, including members of the Stolen Generations. Firstly, a little housekeeping regarding our Zoom session today. At the conclusion of the talk, we'll have some time for questions and answers. If you have any questions, you can submit them throughout the seminar using the chat function, which can be opened using the chat tab at the bottom of your screen. Today's seminar will be recorded and uploaded to our website within a few days. Please keep in mind if you turn on your video to ask a question that your image will be included in this recording. Today, we'll be hearing from Dr. Sophie Haywood. Sophie is a clinician researcher and an APA sports and exercise physiotherapist and works at St Vincent's Hospital, Melbourne, the Melbourne Sports Medicine Centre and Hydrofunctional Fitness. She has an honorary appointment to the School of Physiotherapy at the University of Melbourne and is on the advisory board of the Centre for Health, Exercise and Sports Medicine. Sophie's PhD focused on biomechanics and exercise in older adults and in people with knee osteoarthritis. Her current research project is exploring training in trauma-informed principles with a wide range of collaborators, including those from St Vincent's Hospital, Melbourne, and the Royal Brisbane and Women's Hospital. Today, she will be presenting on trauma-informed principles of safety, trustworthiness, choice, collaboration, and empowerment in physiotherapy and in multidisciplinary rehabilitation. And just a fun fact, Sophie and I actually used to work together many, many years ago, so it's lovely to see her. So welcome, Sophie, and over to you.
Thank you very much, Amy. Yes, it was a long time ago that we worked at Western Health together, but also very nice to see a familiar face. Thank you. I'd also like to acknowledge the traditional owners and custodians of the land on which I'm joining from, the Wurundjeri people of the Kulin Nation, and pay my respects to elders past and present, acknowledge their continuing culture and connections to healing and land, and welcome any Aboriginal and Torres Strait Islander people joining the session today. I'm going to be discussing a study that we published in January, which is mainly connected to physiotherapy, and would like to thank support from St Vincent's Health Australia funding and some fantastic collaborators, particularly Jenny Setchell and Sam Bunsley in Queensland, and also acknowledgement to amazing consumers we've got connected to this project. I'm also going to touch on a project where we've just got some preliminary data to share, and it's a multidisciplinary rehab unit project exploring trauma-informed principles. And I'd like to acknowledge Nadia and the physio team, as well as the allied health and nursing clinicians, as well as other collaborators connected to that project. So I'm mainly going to be talking about the physio project, but I'm going to touch on some insights into multidisciplinary teams that we have in early results from the second project. So in this session, I'm going to talk a little bit about trauma and the principles of trauma-informed care that we used in our project. I'll define our research studies and then look at the key practice considerations. I'm going to finish off by talking about psychological safety for clinicians and self-care for staff, and then touch on next steps. I really welcome any questions. This is a fantastic opportunity for feedback about our projects and connection to this emerging topic of trauma-informed care, and just recognising that there's many people out there doing amazing work in this area. I will be talking about trauma, and there may be aspects of this content that's challenging, and it might not be now while you're listening to it. It might be when you're reflecting on it later. But if at any time during the session, please feel free to obviously take a break and just recognise the impact of these kind of topics. And if you need to, after the session or in further down the track when you're thinking about these things, seek out a trusted friend or colleague to debrief with or seek some input from a healthcare professional. So I'm going to start by defining trauma, and it can be defined in many different ways, but it mainly relates less to the event of what happened, but more to the felt experience for the person and the effects of overwhelming stress linked to trauma. There's a fairly significant limitation in the way we define trauma, and it's considered that we should have a much broader definition of trauma, which relates to things like neglect or any kind of overwhelming experiences. This might also include things like grief or loss of identity with a significant change in life circumstances. It may also relate to microaggressions and intersectionality, which is areas we know much less about. And 3/4 of the Australian population have been exposed to a traumatic event. And so the statistics on trauma are quite shocking. And many of you will know in more detail the different populations that have got higher connections to trauma history, including women and people with a disability or Aboriginal and Torres Strait Islander people. And there's also one study that's very well known, which is the Adverse Childhood Experiences study that was done in the US, that looked at a range of different exposure as children to emotional or psychological abuse, like neglect or being shouted or sworn at, through to physical abuse or sexual abuse, as well as household dysfunction, which included things like a caregiver or parent being incarcerated or having issues with substances or other dysfunction in the household. And they found a really significant correlation with connected to adverse childhood experiences and increased incidence of physical health conditions, chronic physical health conditions in adulthood, as well as medically unexplained symptoms. And beyond physical health conditions, obviously also increased incidence of mental health conditions, as well as other things like issues with engaging with education. So the ACE study is really well known, and these are some of the figures related to chronic conditions. And if the participants were exposed to 4 categories of adverse childhood experience, they had nearly a 2 times increase or likelihood of having cancer, more than 2 times likelihood of having a stroke and a cardiac condition, nearly a 4 times likelihood of having a chronic respiratory condition, and it goes on and on. So they're really shocking statistics, I think. And as a physio working in what would be considered primarily musculoskeletal health or chronic disease in a private sports medicine setting, to see some of these things being more directly correlated is really important for us to understand. Also, you can see a 2 to 4 times increased likelihood of having a mental health condition. So in this slide, it's been broken into different body areas or health conditions. But what we know is that we need to shift towards whole person care, and that it's not that useful for us to just break these things down to physical or mental health conditions, and shifting to whole person care is ideally where we're heading, even though our health system perhaps doesn't help us in that regard. So just in summary, trauma is common, it's harmful, and has the potential to have a significant impact on people's relationships, life and health. In many circumstances, people are exposed to something traumatic and they're able to process it. They've got the support to be able to move on, and it may not have a significant ongoing effect on people's lives, but there's a significant amount of evidence now that indicates, particularly for children and on the developing brain, as well as other circumstances, it's not about the size of the event or specifically the event necessarily, but for many people, the experience can lead to a really significant impact on their health and their life. And that relates to many different systems that become dysregulated, as well as chronic activation of things like the autonomic nervous system. And there's many popular books on polyvagal theory that are very mainstream now, but it also has impacts on things like the neuroendocrine system and the immune system. And impacts on how we regulate our emotions, as well as the way people store memories and how they're able to listen or attend to a conversation or problem solving. So the impacts are really, really significant for people. And then we recognise that healthcare interactions are also really stressful in most circumstances for people who are clients who are within a healthcare setting, as well as carers or family members. And some of the coping behaviours that people may have had in certain traumatic experiences that they'd had in the past may lead to dysfunction in their communication, or them becoming dysregulated within when they're becoming stressed. So that can mean that they're hyper aroused, or they may become angry or very agitated, or they may have very low arousal and become non-responsive within a healthcare interaction. And it's really important for us to start to think about understanding this further, so it can influence the way that we work. Just to be super clear, that trauma-informed care isn't about treating trauma. It's not about counselling or anything connected to that. Being trauma-informed is just being sensitive to all the issues that I've just described, and employing a strengths-based empowerment model for people. And the goal of trauma-informed care is to reduce the likelihood of someone being re-traumatized in a healthcare setting and promote healing and recovering. So it's a little bit, when I think about it, about equity in healthcare. We know that people with complex health conditions often have trouble getting the type of healthcare that would be ideal. And if anyone's read any of the Equally Well statements connected to the really shocking statistics on physical health conditions and poor health outcomes for people with mental health challenges, that what we want to do is support people to have the best healthcare experience that they can have. We know that trauma-informed care contributes to better health outcomes for people. Mainly this has been tested in mental health settings. So there's the criticism of trauma-informed care having kind of loose definitions and not being clearly operationalised, as well as the impact of it not being clear beyond improving the client experience within healthcare. But certainly in mental health care settings, there's definitely evidence to show that there are better healthcare outcomes. This is a really great quote from one of the consumers connected to our project, which I felt really strongly summed up what we're trying to think about with trauma-informed care. And they said that a setback or being pushed over the edge by stress can be something really obvious. You might be in pain, or you might have had a negative interaction with someone, or sometimes you actually don't know what it is that's pushed you over the edge, or given you a setback. And within that setback, all your issues come flooding forward and can be overwhelming. And this might happen to a person within a healthcare setting. You might see it happening to them, and as I said, they become hyper aroused or hypo aroused. Or it might be something that they have a really negative healthcare interaction and it happens afterwards, and that might lead to them not being engaged in healthcare again in the future because of this negative outcome. So sometimes I find that the language around re-traumatization comes from psychology and psychiatry and counselling, and as a physio, it's not a language that I feel very clear about. But this quote talking about having a setback or feeling pushed over the edge and having all of someone's issues coming flooding forward and being overwhelmed, that makes a lot of sense to me. So trauma-informed care is also what we would consider to be a universal precaution. So we don't need to define whether someone has or hasn't had trauma to be trauma-informed. We consider that we should be trauma-informed all the time, given the high prevalence that we know of trauma within the community and the likelihood of people having stressful experiences in healthcare. So we shift towards thinking about the relationship we have with people and their life experience, rather than just thinking necessarily about our technical ability as a clinician or a staff member. And as I mentioned before, we move for everyone to think about whole person care, rather than siloing mind and body or physical health care into two separate components. So trauma-informed care as a universal precaution is what we're interested in exploring. In the projects that we did, we used the Fallett and Harris principles, which are safety, trustworthiness, choice, collaboration, and empowerment. And you can see a definition of those here. They're really important elements of what we looked at in our research studies as to whether physios attended to these principles, what they understood about them. And safety looks at emotional and psychological safety, not just being physically safe within a setting, and that interactions within healthcare are welcoming, respectful, and engaging, and that as staff members, we're attentive to signs of unease. Trustworthiness relates to making sure that there's clear boundaries, whatever's going to happen with an interaction is clear, and then we're maximising honesty, transparency, and consent. Choice and collaboration, I think, are more obvious to us working in healthcare, and they're things that most of us have been working towards in everything that we do, and thinking about really having serious respect for a client's life experience and their history and their opportunity to have input into the control they have of their healthcare experience. And then empowerment relates to strengths-based focus on building skills and recognizing that even when people are in a very difficult circumstance, they do have resources and skills. So the aim in our two studies were to understand the client perspective related to trauma-informed care and explore how clinicians attended to these principles and what they perceived the barriers and enablers to trauma-informed care to be. And then for us to think about what are the next steps, what are the opportunities for practice change and training. The methods in the physio study, just briefly, this was a qualitative study. We did 12 ethnographic observations of clinical practice. 10 of those were in inpatient settings, in gen med and surge settings, wards, and also rehabilitation and geriatric evaluation and management units. The majority of the participants as clients of physiotherapy were over 60, and there were 2 observations of outpatient musculoskeletal consults. Then we had 6 group dialogue discussions with a group of about 16 physios, talking about trauma-informed care and physio strengths and weaknesses related to these principles. And then we interviewed the clients that had physio. And then we looked at critical reflexivity in thinking about examining our assumptions and beliefs and values connected to established clinical practice within physiotherapy. And then we mapped these to trauma-informed care principles. Within the multidisciplinary study that we've just finished, we did focus groups with allied health and nursing staff talking about barriers and enablers to trauma-informed care. And I think there were about 14 clinicians involved in that study, and it was only the 2 social workers that had experience with training in mental health and trauma-informed care specifically. And we did interviews. There were about 30 clients on the rehab unit that were involved in that study, and about half of those were interviewed. We also took some data from the functional independence measure and the hospital anxiety and depression scale for the clients involved in this study. I'm mainly going to talk to the findings of the physio study, which these are the themes that we mapped to the principles of trauma-informed care. And what we found is that physios already attend to and practice some very important elements of trauma-informed care related to psychological safety, which is that the clients feel like they're not just a number, they're being listened to. They feel like their experience, their symptoms and their stories being validated by physios, and that physios were friendly and kind and approachable. And there's a quote here, "I'm right here for you," is things that we saw in the consults. So this is really important. We can lean into the strengths that physios already exhibit in their the way that they build a therapeutic relationship and alliance with a client. And we also saw similar themes within the multidisciplinary team, that staff already exhibit strong elements of attending to psychological safety and validating a healthcare experience, which is really important. For physios, safety often means physical safety, so predominantly falls risk. And you can see the quote here, "I think you attend to psychological safety as much as you need to achieve the physical side of the consultation." And physios often thought that attending to psychological safety or mental health concerns was kind of like opening a can of worms that they didn't really want to go too close to unless they really had to. And I think within what we understand now about the principles of trauma-informed care is that we need to have a strong relationship, and we need to prioritise psychological safety first and foremost for both the client and the physio, rather than think about it as a secondary consideration. Physios were seen in the consults, and we discussed in the focus groups as having a default as a very positive and upbeat approach. And trauma-informed care involves hope and being positive and constructive for the future, and this is useful. But as a default, physios can sometimes be too upbeat and too positive, and sometimes it means that they're not listening to negative emotions or acknowledging negative emotions or meeting people where they are at in terms of their psychological or emotional well-being. So it's a good pause for reflection for physios or other clinicians, and maybe there's other clinicians that our default perhaps too, if we're not quite sure how to manage other comments. And I'm not going to talk about risk communication or disclosures or attending to family violence within this session today. But there are some limitations in, again, people not wanting to necessarily attend to negative emotions because they're not totally sure that they may be doing or saying the right thing. And this came from the physio study. Within trust, there were two main things that came out from the physio study, which was informed consent needs to be taken more seriously as a genuine choice for partial consent and input at that point in time. And of course, this is context specific, and in many circumstances, consent looks different in different circumstances. The second element that we found related to trust was about physios' comfort with touch, which meant that they were very good with the empathetic use of touch, but in terms of thinking about touch being connected to trauma for some people, that physios maybe use touch without thinking too deeply about what it might mean for other people. And it's just a pause for reflection for us to consider that in a more comprehensive way before using it for manual therapy or assisting people to mobilise, as well as expressing empathy. Physios generally provided fairly limited choices, and you can see an example here of what that might be within a consult, and the opportunities for someone to take a pause or have a greater input into how their session unfolded may be a practice consideration for physio moving forward. Collaboration, physios were really good at talking about doing things together, and really interested in collaboration related to goal setting. And this was also a theme throughout the multidisciplinary team as well. There was variable consideration of the life experience of the patient. You can see a really nice quote here from one of the physio participants that they would use with the patient, that they are recognising that the client is, you're the expert in your symptoms and what's happened and what's worked for you in the past, but maybe I just bring a different viewpoint and a different approach, and so I can offer some suggestions. And that's a really nice way of recognising life experience. And there was also discussion that physios can often talk about, you know, saying, yes, I know that things are difficult, or I know they're challenging. And in reality, often we don't really know what someone's going through. So probably talking about I know in a consult might be downplaying that recognition of life experience. It won't surprise anyone to know that when workloads become high and when stress is higher and increased complexity within clinical loads, and this is also true within the multidisciplinary team, that the physios will lose track of the patient experience and become more focused on what they need to tick off or become more task focused. And this is probably one of the biggest barriers for trauma-informed care moving forward in thinking about how we manage workloads and also be trauma-informed. One of the other gaps in care was related to the principle of collaboration, is physios sometimes thinking that they needed to fix what was going on and trying to push evidence-based care in terms of increasing someone's exercise or getting someone mobilising or becoming more independent, and maybe not considering evidence-based practice more broadly as still involving input from the client in how this might happen. And so there was a sense that sometimes physios were a little bit pushy in the way that they wanted things to happen with the best intentions, of course, but maybe another consideration is for physios to think a little bit less about pushing so hard sometimes and a little bit more about thinking about what might be some of the blockers for that individual at that point in time. There was a little bit of lack of understanding about what the power imbalance might be within the healthcare setting from physios. Obviously, there's a significant imbalance in terms of physical ability, but also we saw physios controlling discharge and controlling next appointments or next catch-ups, and understanding that power imbalance within healthcare is important. Physios were great at focusing on extending physical skills, function and independence, and this was also echoed in the multidisciplinary rehab unit study, and that's really great for empowerment. And there was some awareness from physios about how we build non-physical skills like problem solving, managing pain, those kind of things, and we see a quote here about recognising that sleep can be important. So we came up with some key practice considerations related to those main themes and the principles of trauma-informed care, most of which I've touched on, and happy to share these again at a later date. And then we come to thinking about what the barriers and enablers may be. I've mentioned most of them already. It's often about what we perceive our job role to be, how we manage our own workload, and what some of the organisational pressures might be on us in terms of discharge. And some of the enablers that came out in both of the studies with physios as well as allied health and nursing clinicians is that clinicians feel very engaged and interested in trauma-informed care, and they already recognise it as a way that they can support the best healthcare interaction for the clients that they're working with, but also recognising that it might be a way that they can support each other within a team. And although our project didn't set out to look at psychological safety or trauma-informed care from the perspective of the clinician or the staff member, this is a really important element of something that we need to think about moving forward. And the team does a really good job, whether it's the physio team or whether it's a multidisciplinary team, of doing that already. And trauma-informed principles potentially give us another opportunity to do that. The limitations of the physio study was it was done over a really extended period of time, in that we started it before COVID, and it meant that we had a number of clinicians that came in and out of that project over that time. We need to think about the fact that most of the consultations were observed within an inpatient setting, and thinking about the transferability of findings to other physio settings. And as I mentioned, the study ideally would have had more focus on not just psychological safety for the clinician, but also thinking about cultural safety as well. So in conclusion, physios and the multidisciplinary team already attend to the most important elements of trauma-informed principles, which is psychological safety, helping people to feel listened to and validating their experience and acknowledging their life experience and making them feel like a human and an individual. And this is really important, and it was a great aspect of this study, talking to clinicians, and a real privilege to watch consults to see this. But there are gaps in knowledge and skills, as well as constraints coming from the services we provide, as well as the organisations we work in terms of being trauma-informed. Just to finish off, I wanted to just very briefly touch on psychological safety and self-care for clinicians, because we've come to recognise that this is a really important element of talking about trauma-informed care, and recognising that the principles exist also for staff. And it's really important because we know that there's a significant proportion of the health workforce that's already managing their own mental health conditions, and that we're subjected to a significant number of stresses. And part of that is a responsibility of the organisation to help us manage those things related to workload and resources and staffing. And then we're exposed to other stresses within clinical encounters, which can include trauma and distress, pain, death and conflict. And all of us will work in different circumstances, but I imagine most of us will recognise the significant amount of pressure that's put on people who work in healthcare. And we know vicarious trauma or indirect experience of distress, which relates to the way that we empathically engage with clients in our care, will have an influence on us. And there is an overlap between vicarious trauma and secondary traumatic stress or compassion fatigue. And we need to be really aware of these things. Managing vicarious trauma and compassion fatigue relates to being educated on early symptoms, as well as self-care and stress management, and thinking about how we make a self-care plan for ourselves, ideally not when things go pear-shaped, but in a preventative way as well. And here's a list of work-related stresses, and some of them may be things that you recognise. We'll all respond to stress, whether it's stress in our home life or outside of work, or whether it's magnified with work stress or just related to work-related stress. We'll all respond to stress in different ways, but sometimes it's good for us to recognise when we see certain behaviours or things happening to us that recognises that we're under additional pressure, and that might be a good time for us to consider what we're doing to manage that. We also need to think that managing our physical, mental and emotional health, as well as our social health, is not just about doing it when we feel like we've got symptoms of stress, but also it's ideally preventative. And that means that we need to set boundaries for ourselves within our day-to-day workplace, within our role within the team, as well as talking about that within the teams that we work in, and thinking about how we maintain work-life balance and being clear about what kind of strategies we put into place, and thinking about looking after ourselves and being compassionate to ourselves and making sure we access support. And this is a list from the RACGP. They've got some good resources that talk about different self-care strategies, and self-care strategies will be very individual. Some of these things will be really meaningful for some of us, and some of them will be less relevant. And so it's about us identifying which types of self-care strategies do we think work for us, and how can we make sure that they happen on a regular basis. One of the things that I feel like I learned across this trauma-informed care project was that it's also not just self-care about maybe what I do on the weekend or when I finish work, but also thinking about how we can use grounding techniques, or taking a deep breath, or a short walk, or making sure you give time for morning tea and those kind of things within a working day, and just setting yourself up before your next consult in a way that you feel like you've given yourself a little bit of time. And I think sometimes, particularly when our workloads get higher, it's normal for us to sort of have head down and just keep pushing forward, and sometimes that may not be a very useful strategy that's not that sustainable. So it's interesting for us to think also about our self-care strategies from hour to hour, or between consults or clients that we might see, regardless of which setting that we're in. The next steps for us on the trauma-informed care project at St Vincent's is we've got some clarity now about what the gaps are and how we might move forward with some training. We've identified that there's a tension between clinicians being very connected to trauma-informed care principles, but also some of the organisational and job role constraints that we have. And what we've done so far is piloted training with 50 physiotherapists to look at some of these gaps, as well as talk about self-care and resilience also. And we've done that with the help of a reflection with a Blue Knot Foundation counsellor, which has been really helpful for the research team. And we're looking within what we're calling our uptick training, or upskilling in trauma-informed care training, that our focus is on the training being meaningful and relevant, and that clinicians have got buy-in to the principles, and that they're going to be different in different contexts, and we all work in different contexts, and that makes it really important to be individualised in terms of people determining how they're relevant. And Also, as well as acknowledging the gaps in the way we practice, is just recognising the strength that clinicians already have in trauma-informed principles and making sure that we're reinforcing those strengths. And we're very interested in making sure that we think about how we can measure and describe impact moving forward. And this may be within an individual interaction between a healthcare clinician and a client. It might be improving patient experience or improving engagement with a healthcare service, or it might be looking at a more systems perspective, because until we can be clear about what impact this has, it makes it a little bit harder for us to sell it as being important. Within some systems and organisations, these things are already going to be prioritised, and feeding into organisations' mission and vision is important as well. It needs to be realistic, any training that we do, and thinking about the barriers that we have. We need to think about what our professional culture is, and in physio we have a very technical focus on our professional development and supervision, and we maybe need to think about shifting towards a more relational element of upskilling, and the physio department at the Royal Melbourne is looking into this connected to supervision and debriefing. And it's important that we're looking at longitudinal supported change for behaviour change, as well as the types of resources and ongoing support that clinicians need, as well as a focus on clinician psychological safety. So I've just got some resources there. We've used the Blue Knot Foundation quite heavily for our own professional development, as well as some supervision sessions, which has been incredibly helpful for us. For those of you working in New South Wales, you will already have experience and exposure to integrated trauma-informed care, and there's some really excellent documents connected to that on the New South Wales Health websites. The RACGP White Book has got some really valuable elements related to trauma-informed care, and Joanna Lynch, related to her PhD and her sense of safety and moving towards whole person care, is also a really great resource that you can look into. And I recently did some online training that's come from Western Australia with collaborators in Queensland related to clinical yarning that I found extremely useful. There's a QR code there, and we're really interested in anyone connecting with us if you're interested in being kept abreast of anything that we're doing or publishing, as well as any opportunities for uptick training in the future. We're really open to your feedback, and would be grateful for you to get in touch if you've got anything specific that you would like to let us know about. Otherwise, thanks so much for your attention. It's a really interesting emerging topic. There's been an explosion of research and clinical interest in trauma-informed care, and we're on a big learning curve here connected to the projects that we're doing, and we're really interested in hearing what everyone else has been doing and what they've got to say about it. So thanks very much, Amy.
Thank you, Sophie. So we now have some time for Q&A. So if you have any questions, please submit them now through the chat function. Alternatively, if you'd like to ask your question in person, you can turn on your camera and microphone and we will call on you in turn. And while we are waiting for that, I'm not sure if it's a question or a comment, it's probably a bit of both, but I was just wondering about whether there's been anything looking at the impact of the environment. And I guess I'm thinking particularly around older people in hospital. Many older people in hospital have had previous experience either themselves or with relatives in hospital, which aren't always that positive and may obviously have been traumatic or may trigger new trauma from sort of that experience. And I guess I'm thinking about a family member of mine who was in hospital, an older family member who, when they went into hospital, was recalling an incident that had happened 20 years ago with another family member. And I have to say it really impacted his hospital admission, but also his interactions with healthcare professionals, both in terms of what he communicated and what he took from the communication from health professionals.
Yeah.
So is there anything that you'd like to comment on regarding that?
Yeah, thanks, Amy. I think you're probably getting to a couple of really meaningful aspects of what we're discussing. We did some observations in clinical environments, so not just looking at consults. And we know that the ward setting and within an aged care setting, it can be very busy. Sometimes it's not very private, and those elements of the environment are an issue. Additionally to that, many people have had really bad experience within institutions. So it may not just be a hospital that's led to a really bad past experience for someone, but there's many other institutions, and hospitals and aged care settings can still look like institutions, and that may mean that someone goes back to that place, and it may not necessarily just be a healthcare experience. But I think what you spoke about in terms of that person's experience meant that it really affected their interaction with staff, and that healthcare interaction. The biggest issue is that when people have had negative experiences, that they don't want to be there, they don't want to engage. It really affects the outcome for them, as well as their ability to listen or problem solve or feel safe. And I think that you've probably hit the nail on the head in why we're most interested in clinicians understanding this, is that every behaviour has a meaning. So when we see someone who is behaving in a certain way, they're highly stressed, or they're hyper aroused or they're looking very upset, that we need to consider that in all circumstances we're doing whatever we can to understand and help support that. So I think that's probably one of the most important things that we do, that sometimes in the circumstance that you described, it'll be really obvious, and it sounds like they got to the bottom of what that was, and it still really affected that person's healthcare interaction. But sometimes it might be that we're not seeing that, and that it's happening inside that person, and we as clinicians want to be skilled in understanding that the way we behave will have an impact on people's experience, even if we're not seeing or hearing what might be going on for them.
Absolutely. Yep. No, you're absolutely spot on with that. So thank you for those insights. We've got a question from Meryl. It's a little bit of an intro, so I'll just read it out for you. So, as trauma-informed care is being included as a requirement in the strengthened aged care standards, is it new training required for all staff, or is it more of acknowledgement and naming of what is happening as part of usual or the often approach to care? How might this look different for allied health, in and out of episodes, and ongoing nursing or medical care?
That's a great question. I suspect that there's people who work within aged care policy that have got a stronger sense of what this might look like. But we do see across different allied health organisations talking about competencies in cultural safety, as well as things like trauma informed care. So I think often the stage we're at the moment, and I'm happy to be corrected, is that organisations and policymakers are turning towards wanting to acknowledge this and incorporating it into care, and that relates to training. And that, I don't know that the detail of exactly what that looks like is totally clear, but there may be other people who've got a different perspective on that. I think we're shifting towards wanting training and recognition of trauma informed care. I'm not totally sure that it's exactly clear what that would look like or how that might be enacted.
Great, thanks. So, did anyone want to comment on that? Anyone who's listening in have anything to add to that?
I can make a comment if that's
Thanks,
okay, Amy.
Francis. Absolutely.
Thanks, Sophie, for a great presentation. It's great to hear the initiatives in upskilling staff and the training provision in relation to trauma-informed care. I guess one of the bigger points, isn't it, is like, what does the whole system look like? And that the system, not just the physical environment, but the policies and the systems within health services, aged care for that matter, are often just working against. We can upskill clinicians, we can get better as individuals, but we're working within that system that is really working against it at times. And just wondered if you had a comment about that.
Yeah, that's a really important point for us, Francis. And I think it comes back to us trying to make sure this next phase of our research looks at impact. And the impact will be about clinician behaviour and patient experience, but it's also about service delivery and systems. I think in like larger healthcare organisations that these things are being discussed. I think that the interagency collaboration also becomes really critical, funding mechanisms and what they look like, what clinicians have to do, what clients have to do to jump through certain hoops. And there's many aspects of the way that systems work that create trauma. And yeah, it's 100% mainly not the physical environment, but much more about whether people feel welcomed into spaces and feel supported in their healthcare journey and have true choice, or whether they feel like it's, our way or the highway, and they don't have any clarity about what that looks like. And I think that trauma-informed care really wants to influence systems, because unless the biggest barriers come from the systems for clinicians, they come from workload pressures or perceived job roles. And until we can understand the changes to the system and policy, then none of this is going to make much difference. So that's a really important point. Thank you.
Thanks, Sophie.
Thanks for that question, Frances, and for that response, Sophie. Any final questions for Sophie or comments? Nope, everyone's very quiet. So if there aren't any final questions or comments, please join me in thanking Sophie with your clap reactions.
Thank you. It's been really great to have the opportunity to talk through this. And as I said, it's a learning curve for all of us, and really great, and welcome any feedback.
Awesome. Thank you so much, Sophie. So next month, Yolanda Lindenberg, who I actually think I might have spotted in the audience today, will be presenting the seminar in aging. So please join us online on Tuesday, the 18th of June at 12 o'clock, and keep your eyes on all of our NARI socials for any other upcoming events as well. We've got a few launches underway at the moment. So yes, please have a look at either our LinkedIn page, Facebook, or X. Other than that, thank you very much for attending our Seminars in Aging series today, and hopefully we'll see you all soon. Thank you.